Is the screen visible?
Yes.
Okay. So welcome again, all of you. And we've picked up a very common infection, something that probably all of us suffer from nearly 5 to 10 times in a year. This is very common in children, especially the school children. And in fact, they are the ones often bringing back those infections to the household, which then again predisposes their younger siblings who may be neonates or infants in the house, or the other extremes of ages, the grandparents again. So while this is very common and mostly self-limiting, it can be quite debilitating in terms of the disability. And in case of school children, again, it becomes very important because it leads to loss of their attendance and the school days. More importantly, in some of the extreme ages and in some of the cases with pre-existing comorbidities, uh, extreme of ages in terms of infants, so let's say less than 2 years of age, and existing comorbidities, let's say those who are having some sort of a cardiac condition or pre-existing lung conditions, known allergic histories. In such cases, they can even lead to very critical infections, which causes hospitalizations. Now, it spreads fast. Um, Therefore, glitching the diagnosis becomes very important. Once we know, it is easy to implement very simple methods and practices which can prevent the spread, gives an idea about the time for which such patient should be preferably isolated at home and minimize the contact. Again, some basic practices can be taught so that there is less spread or aerosolization of these infective agents. As also, the diagnosis will also help in instituting the correct therapy. Now, the most common causes are such where therapy may or may not be available. So in a way, the diagnosis also helps in limiting unnecessary use of certain antimicrobials. So this is the theme for today's webinar. And I will let our expert speak on the same from his clinical experience, which will give us an overview of what is the kind of cases, the kind of symptoms these patients present with, how has been the journey for him when he has convinced the parents for the need of the diagnostic test, how has this test helped him reach a diagnosis, make clinical decision, limit the use of antibiotics, and what has been the value addition to the patient and the improvement in the medical condition of the patient. So I welcome Dr. Suhas Kulkarni, who has 35 plus years of experience in treating pediatric cases presenting with varied symptoms, both infectious and non-infectious. And Sir has been a consultant pediatrician and a proprietor of Chiranjeevi Hospital at Thane. He's also associated with a number of other hospitals at Thane. He's a very renowned practitioner. And I must say, I find him as a very modest person, very knowledgeable. So, sir, I'll not buy more time. Over to you for giving us the clinical insights.
Thank you, Dr. Mahua. And can we quickly go to the next slide so that we can go to see Dr. Mahua has already given you a proper introduction of today's sort of topic. It's it's quite important to note that as of today, patients are very keen on knowing what exactly is happening to them, or in this case, the parents are keen on knowing what's happening to the child and whether a treatment is available or not available. How long will it take to become okay? In today's age, time is such a most important thing, and how many days is it going to take to become better? What are the treatment modalities and things like that? So we will see how this particular testing is helping us to arrive at a diagnosis and how it helps us, as she rightly mentioned, to manage the children in today's age and time. Okay. Yeah. Next, please.
Did the slide move, sir?
No, it does not move.
Okay, at my end, it shows it's moving.
Acha. So,
Hello,
should I take over
Yes.
the?
Ma'am, we'll share the screen. Just a minute.
Yes, sir, you can take over. I think that's a better idea.
Yeah, that might be better. If you can give it to me, then I will take it.
Yeah.
Have you given it to me?
Is the screen visible?
No, it is still the same. The screen is visible, or it is still the same. It has not changed. Yes. You given control haystack. Can I try and control it myself? Can I see? Can I see whether it can do? I can do it. Because showing control haystack analytics slides. Let me see if I can control. No, I cannot. Ah, yeah, I can. Yes. Yes, I can. Fair enough. I think it is. Is everybody able to view the slide, please? Can someone respond?
Yes, sir. Yes, sir.
Yeah. Okay. Right. So now, yeah, so we were talking about respiratory infections. Of course, here this is a overview of all respiratory infections or most respiratory infections, not necessarily just the flu. But if you look at this, that you will realize that in children under 5, it is the leading cause of mortality. And across age groups, it is the sixth leading cause of mortality, the respiratory infections. And pretty obviously, across the globe, the burden will be variable, much more in the underdeveloped and socio-demographic, where the demographic profile is low. You would find the mortality more. And obviously, it is also, we know, as Dr. Mahua also has mentioned, it disproportionately affects the very young children, and in the extremes of age group beyond 65 years of age also, plus those who are impoverished in not having access to proper health care, and also those children with pre-existing conditions, whatever she had mentioned. Okay, so this is a slide showing the various pathogens which can give rise to respiratory infections. And if you, the left side is showing the total deaths in just numbers, whereas if you look at the right side, the lines are showing the rising trend of these infections in older age groups, or rising mortality of these infections in the older age groups. So it's pretty obvious that the mortality is much more in very old children, old people also. Next one, I'll take the next one. 1 minute. Yeah. So, yeah, we are low. When we talk of influenza, we are basically talking of a virus which affects the lower as well as upper respiratory tract, and the transmission is uh, most commonly through droplets itself. That is, when somebody sneezes, you pick it up from the air, and that's why it's much more common. You see them in school children, because it's in a closed room. When you have one child coughing, and that child especially can easily transmit or make it, it becomes contagious for his neighbors who's sitting next to him or her. So that is how it goes, and of course fomites too. So when, from what period is it contagious? From about a day or two before the symptoms appear till at least about a week after they start. So it's quite a lot. It's nothing to, you can't avoid. That's the reason why when the child is suffering from a very bad cough and cold, we always tell the parents, don't send the child to school. We saw it much more during the COVID period, when we found the contagiousness was definitely much more, and the consequences also were much more serious. But even in flu, it's important, and we must also understand that now we are again seeing a surge of COVID. The presence of the flu itself is going to cause low immunity, and that may make the child or the adult, whatever, more susceptible to COVID. So that's another reason why we need to ensure that this is kept under control. Yeah. So what about the seasonality? There are two clear seasons in India. The one is, of course, the post monsoon, which we are facing now. I'm sure many of you must be already seeing lots of cases of flu. And again, Jan to March, just after the or just during the winter season, we do see it in most states. Yeah. So next, please. Wait, I'll do it. No problem. Sorry. Yes. So we've already seen this extremes of age, more than 65 and less than 5. I would say less than 2. Yes. Dr. Mahua has already said that. It's important, and in small children, much more. In fact, I recently had a child, that 11-month-old child who came with acute bronchiolitis. And to my surprise, the child responded within 48 hours. The child stopped, everything reduced, the fever went down. Child came very breathless and his saturation was 85% on room air. We gave a little oxygen through the nostrils. I mean, just the, what you call, through simple oxygen by nasal cannula. Did a flu test and we got the result as rhinovirus. I mean, that's the common cold. And that's why the child immediately responded within 48 hours. So I could explain it to the parents, don't worry, this child is just simple common cold, but it has, because of the small age group or young age group, the child had a little severe infection, but this child will respond. And child, within 2 days, we could discharge this child. So like that, that is also one of the factors. Then weakened immune system. Yes, we know all these patients, especially with cancer, HIV, AIDS, and transplant recipients, they can be more. They are more at risk. Illnesses, diabetes, heart disease, hypertension, and wherever the and pregnancy. That's another group which can which should be more at risk. And of course, obesity. We are all aware that it impairs the immune system, and that can also obese patients can be more susceptible. And the environmental factors, our situation in the urban areas, especially the urban slums, and there's overcrowding. And I already told you about the school rooms. The classrooms can sometimes be overcrowded. Most of the schools usually have 50, 60 students in one class. And sometimes some of these schools also have air conditioning. And that also causes the susceptibility to spread of the infection. The causative viruses, of course, are flu A, flu B. Then you have the H3N2 and influenza B. Antibiotics are, of course, ineffective in these cases. The flu-like syndrome, all these viruses can give rise to a flu-like syndrome. Even certain bacterial infections like strep pneumoniae, mycoplasma, varicella. See, it's difficult to a very small child who cannot really speak or whatever, and it's difficult to come to a diagnosis by just examining the child or taking a history, because most of them would come with fairly similar symptoms. There are very little what do you call differentiating factors. We used to always say mycoplasma is a uh, walking pneumonia or whatever, but I'm sure many of you must have recently experienced there was a what do you call, a little bit of a not a pandemic, but some endemic some cases of mycoplasma pneumonia which we saw in the last maybe few months, where they came with fairly severe infection or severe symptoms. They had bad breathlessness and high fever and things like that. So you can't really say that it's a walking pneumonia. Nowadays we do see some serious cases also, and of course the other infections like varicella, H influenza, and all that. So antibiotics are required only in these cases, whereas it won't really help when you have a flu-like syndrome. I mean, when you have flu. So let's look at the clinical overview of flu. I just said that most of these pathogens would give us to a fairly similar presentation. We say that when you see a runny nose or a cough, or this runny nose is usually viral and not bacterial. But in many of these cases, you would see. Yeah, just give me 1 minute, please. Hello. 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 Sorry. Yes. Yeah. So these are the common symptoms which you would see in most of these viral infections. There would be some body ache, headache, sore throat, runny nose, and in small children you would see a lot of vomiting also, most common. Sick to the stomach. When I saw the sick to the stomach, I checked it out actually. To what extent does it mean? It only means a very sick child, a child who's very irritable, who's not feeding properly, and things like that. So it doesn't necessarily mean something to do with the stomach. It just means it's a idiom or whatever you want to call it, which means that a child who's quite sick and who's not comfortable at all. So you, of course, and many of these viruses in small children would have multi-system involvement, so you would have vomiting and diarrhea also. It's very common to see a viral infection presenting mainly with vomiting and diarrhea, and they also have bad coryzal symptoms. The data in India is not too much. I mean, that's mainly because many of these areas, especially rural areas and some of the other urban areas too, do not have access to too much of testing. So you would not really find it. Uh, the but whatever cases we have seen, we have found at least in the 2023 till the surveillance data till 23 is shown out here till March 23. The states with the highest H1N1 cases were Tamil Nadu, even Maharashtra, Gujarat, whatever reporting cases were there. So we do have a burden of flu in India too. These are only some of the data. The entire data is definitely not available, but and many of these infections can be quite severe. The data is mainly from the ICMR network, of course. Uh, yeah, just one minute. Just one minute. Hello. Yes, sorry. Yes. So, yeah. So just to tell you that there is a burden in India, which needs to be addressed. Uh, Correct. Value proposition of early diagnosis. Why is it important to know the diagnosis early? Again, same thing. Uh, as I told you, I think time factor is most important. If we know early that this child is suffering from an illness which may not respond to antibiotics or may not need antibiotics, we can stop that, and it's very important for the purpose of what do you call antimicrobial what do you call proper therapy, to ensure that we don't give unnecessary antibiotics. So that stewardship becomes very important out here. So I think most good pediatricians don't immediately start on antibiotics anyway. So it's only when we come to know that this is probably a bacterial infection, then we would use. So this test which comes, we'll see it soon. It's got such a beautiful turnaround time that within 24 hours you come to know what kind of infection it is, rather than waiting for a culture which may take 3 to 4 days also sometimes. This helps a lot in coming to a immediate decision whether to start on antibiotics or to start on antivirals, or don't give any treatment at all, just give supportive therapy. Okay. And I think we were just discussing before this started. It's important always for the parents to have a diagnosis, because they always want to know what is wrong with their child. So if you, I think many of you must have got this. Like if you tell them that child has a viral infection, but they don't believe it unless they see something in print. So if you show them something in print, okay, this is there. You got this is the rhinovirus, or this is this virus. So then they are a little bit, it's easy for us to counsel them also that it may take so many days. You don't require to give medications and things like that. So the reduced costs is very, very important. Reduce healthcare costs in our country, and also improve health outcome, ensuring that this child who has a viral infection, as she has rightly mentioned, to keep the child a little isolated and ensure that it doesn't spread to others. And community, yes, same thing again. Better infection control, reduce spread, and improved caregiver well-being, and improved antimicrobial stewardship practices that you just mentioned. Okay. So this is a very new thought in the diagnostic parlance of what we call next generation sequencing. We are all aware that up to now, whatever the tests that we had, other than the cultures and all that, we did have testing, but they were doing what we call as the uh, what is that? The but what do we call it when we take up the genetic material? Yeah. So here we are doing directly from the yeah, PCR. So rather than PCR, here we are doing it actually directly from the clinical material itself. I think it makes a lot of difference. We are not using PCR here. That's why it's faster also and more accurate. So it's no time consuming what do you call things are there. It becomes a single all inclusive diagnostic test. It's very, very useful. I've found it extremely useful. So it comes as a one test solution, and for all these similar symptoms, we can come to a solution very fast. Okay, and to know what the exact diagnosis, and it's comprehensive. If you look at the entire what do you call menu that they have, It looks after, I mean, some 13 to 14 viruses are being isolated and checked out on, plus a host of bacteria. And that's amazing because most of the bacteria that they're mentioning about, they are not really grow. It's very difficult to grow on a culture, even if you wait for 2 days or 3 days, whatever. So it's extremely useful test for that matter. So there's no culture, as we rightly mentioned just now. The accuracy is very high. It's a single test for all the major flu infections. And as I told you, it's a direct sequencing from sample itself. So it is not, it differs from the PCR. The technicalities, of course, Dr. Mahua will tell you a bit later. So when we say evidence-based medicine, what exactly are we saying? See, there is always, our medicines or whatever that we give, the therapy that we give or the medicine that we practice is all based on research, evidence after research, okay, what the literature says. And then over a period of time, there's a clinical expertise, what the clinician also knows and understands and practices throughout. And through this, we also come to a conclusion as to what the patient wants. So ultimately, we have to cater to the patient or the patient's relatives. So that is what is evidence-based medicine, that you tell the patient or you are able to counsel the patient that this is what is the evidence available, and with my clinical expertise, this is what we are treating. So it becomes much simpler for us to counsel the patients, and that is what this test helps us. Okay, so these are some of the viruses which are covered by the FLU-NGS testing. And yeah, so before I go ahead, I think what are we ideally looking for in a test like this? We want, as we rightly mentioned, we want a rapid diagnosis. That is one of the things. Second, it should be affordable to the common man. It should not be costing in tens of thousands. So there are some of the PCR tests which are there right now of these respiratory panels and things like that. It should have a quick turnaround time. That is what we are seeing just now. So if we have of these things if they're taken care of, then there's nothing like it. I mean, plus it should cover most of the pathogens. So all that is taken care of very well by this test. Okay. So these are some of the viruses that we are covering, which also includes the human coronavirus, which are now they have added this OC43 and all that. There is H1N1, H3N2, which was that, as I told you, the epidemic in the recent past, or if you're aware of that. And the SARS-CoV-2 is there. Adenovirus. I must tell you the story of the adenovirus, because last year we had cases of adenovirus. That time, unfortunately, this was not available. But I had a child who had to be treated in the ICU at Kaushalya Hospital for a pretty long time, for 14, 15 days, and the child was not responding. And finally, we realized that it was adenovirus. And then, with all these complications and super and bacterial infections and everything, the child ultimately responded. But adenovirus can be tough in a small child, especially with coexistent. That child also had some respiratory, like there was hyperreactive RV also. So it took a long time for the child to come under control. So adenovirus can sometimes be bad. Rhinovirus, of course, the common cold virus, which I had one case just a few days ago, and we could counsel the parents, as I told you just now, that this child, you're lucky the child has just had a cold which has developed into what do you call, a little bit of a breathlessness and bronchiolitis, but the child responded very fast. Yeah, this is a technical overview, which I think Dr. Mahua, can you take over and just explain for the next couple of slides? Yeah.
Yes, sure, sir. Thank you so much. This was very informative, sir, from the clinical standpoint. I'll just see if I can move the slides myself.
You want me to move? I'll move it. No problem. Yeah.
Sir, I would prefer to move it on my own.
Okay.
Mayank, can this be enabled for me?
Dr. Mahmood, just 2-3 slides. I can help you. You can just one and the next one. Go ahead.
Oh, okay, sir, I got it. I got that bar where I can do it. I think it was not through my keyboard, it was through this. Now I know how to do it.
Yes.
Okay. Thank you so much, sir. Before I move on to speaking about this test, I want to share this journey of developing this test with all of you. Why did we develop this? So in my experience when I was working as a clinical microbiologist in a hospital, what I realized was that this was a burdening problem. For most of the pediatricians, this was one of the most common causes of whether it be a PICU admission or an OPD visit. Respiratory infections topped the list. And most of the time, they were forced to go in for empiric therapy because a definitive diagnosis would not be available. The reason being either the technology was not available for diagnosis. So what we realize is PCR is the most common technique which currently is being used across India. And the affordability or accessibility of the same was a challenge. So tests which were available, which were quite comprehensive, which were film array based or multiplex PCR based, they were coming in with a huge cost. So most of the times, especially in cases where a clinician is suspecting a viral infection and knows that despite the diagnosis, there is not much intervention that I will be doing. There was the threshold of prescribing such tests was very low, right? So it was all based on empiric therapy. They would give the supportive therapy and then they would add an antibiotic for suspected secondary bacterial infections. So the need was high, but access to such tests was low. And the major blocker was the cost involved. The second thing that I observed was that whenever they would still, in rarest of rare cases, did prescribe such a test, they had to split the sample between a PCR panel, which would address the viruses mostly, and a few bacteria, maybe one or two. And as I speak, even the best of panels address only very few bacteria. And the rest of the sample would be sent into the lab for culture in order to detect any bacteria if present, especially those causing the URIs. Now, the challenge was that such infections are caused by bacteria which are either very difficult to culture, almost non-culturable in a routine microbiology lab because they need very special resources. For example, if it is a chlamydia or if it is a mycoplasma, a routine microbiology lab will be quite incapable of growing and reporting such organisms. It would need a research institute for the same. Or even if they grow, they are very difficult to detect and isolate. Let's say a strep pneumoniae. Most of the time, the growth on the plate would be hidden by the other rapidly growing commensals of the throat, which meant that though they were ordering for a culture, the results that they were getting were not fitting into the clinical diagnosis and more or less was of no use to them in the clinical decision making. So again, whether either they were not testing or if they were testing, fortunately, they may get the reports of a few viruses, but as far as bacterial co-infections or mono-infections were concerned, they would again be stranded and it would be empiric therapy that they would depend upon. Now, given this situation, we realized that we needed a test which was accessible to everybody and not limited to tertiary healthcare institutes, which means it had to be priced at a certain cost where the threshold of prescribing goes down so that the clinicians are more comfortable advising the test to the parents and the parents are more comfortable in trying to know the diagnosis because it's not a pinch to the pocket. I think this was a very, very important consideration when we were designing this test. The second was the comprehensivity. We wanted it to be a one test solution. Again, we did not want to burden the clinician or the family writing multiple tests and paying for them to get the ultimate diagnosis. So what we realized was let's cover the most important viruses. We more or less had some idea about the Indian epidemiology thanks to the viral surveillance networks by ICMR and some of the existing PCR technologies. So we have a fair world over global as well as Indian overview of which are the predominant viruses which cause upper respiratory infections and sometimes go on to cause the lower respiratory infections as well. And as far as the bacteria or the fungi were concerned, we wanted it to be as broad as possible, covering all the flu-like bacteria, flu-like illness-causing bacteria. That was very important, that nothing should be missed. At least let's not miss. And that is what gave birth to this test, which we named the FLU-NGS, pricing it again at a point where the clinicians found it to be very comfortable for the OPD cases and as also for their critical patients. So what exactly does this test do and how does it work? Now, more or less, most of us have either used or are more familiar with PCR technologies. PCR, in order to develop any PCR test, we have to design something called the primer. These terminologies are more familiar nowadays thanks to COVID-19. It has sort of educated us in molecular techniques and it has sort of upgraded most of the labs into molecular labs nowadays. So if I have to detect something using a PCR technology, what I need to do is, if you consider that something as a lock, then I have to create a key. And that key is the primer that I have to design. I have to decide how many such locks can I unlock in a given test. So a PCR would, let's say, have at the most 20, 25 or 30 targets in a single test. And those many keys or those many primers would be present to unlock, right? Now, if the lock changes anytime in the natural history, which viruses are very prone to, then this key will not work. So that test would fail in detection. Whenever such a key has to be designed, the research and development unit of such PCR diagnostic laboratories have to fall back on the sequencing data. They first have to get the sequencing data, find out portions which are unique, then design that primer for their PCR test. So we thought, why should we bank upon a PCR technology, which seems to be, I always prefer using this term, the baby technology, where the mother technology is the sequencing. So why not go back to sequencing itself? Why not find out that length of information, which makes it more accurate? Because I'm reading the DNA or RNA in the actual sequence that it is present in. I'm reading a very long part of it, gives me the precision and the accuracy. And it also is making me agnostic to any change in the virus, which means that even if there are newer variants, I'm still able to detect, right? So basis this, we designed this test, which is sequencing based. Okay. Now, of course, it had to be direct from sample so that there is no question of performing a culture for bacteria. While viruses are cultured only in research labs or in labs with tissue culture facilities, and those are just research work because such a facility or such a technology cannot be used for clinical decision making given the resources and the time constraints. So for bacteria, again, we didn't want to fall back on culture. So had to be direct from the sample. In this case, the sample is the OPNP swabs. Again, it had to perform within a stipulated time, which is very useful for clinical action taking. So clinically actionable time frame was important, and we realized that within 24 hours, if a report can reach to the family and to the doctor, they can make targeted interventions. It had to be near or on site, which means that this technology had to be made accessible to every city and to try and make it even approachable to most of the doctors, GPs, clinics, nursing homes, so that everybody can benefit from this. And as I mentioned, it had to be comprehensive. So covering most of the viruses so that different tests need not be prescribed to address different viruses. Limited panels do not have to be banked upon. And as far as any co-infection with a bacteria is concerned, or primary infection, which is mimicking a flu but is being caused by a bacteria, also doesn't go unnoticed. And of course, if we are using sequencing needs to have a very, very robust bioinformatics in place for highest quality control, accuracy, precision, and reproducibility. PCRs use a different technology for the detection part, which is probe dependent. That creates some fallacies that does limit some of the specificity. I'll not go into the technical details of the same. But again, when it comes to sequencing, the interpretation or the decoding of the sequence. So a sequence is like a code. It is almost like a Morse code. So there has to be an expert who can decode it for us. That expert is a bioinformatician. But if it is left to a human, it will be again time consuming, error prone, and cost intensive. So we automated the entire software. We automated that entire pipeline to ensure that the strictest and highest level of quality controls are in place, so that once a report goes out to a clinician, we can claim 100% accuracy. So if something is calling out COVID-19, a SARS-CoV-2, the clinician can be rest assured, the public health can be rest assured, the family can be rest assured that this is an absolutely accurate diagnosis, which again sometimes is a challenge with PCR techniques because of cross-binding of primers. So there are sometimes erroneous detection, but in this case, we have enabled this precision using the proprietary software that we have created. What we do the sequencing on, just for interest, is called a MinION. It's a very small pocket held device. In fact, this device, which has been developed by Oxford Nanopore, a company based out of Oxford, has enabled sequencing to reach most of the tables because of the very small capex and the cost slashing that was achievable and the scalability that this has enabled. So what exactly happens when a clinician thinks that this might be an infection involving the upper respiratory tract, or might also have caused descending infections to involve the lower respiratory tract? A very easily accessible sample is the OPNP swab, the oropharyngeal nasopharyngeal swabs. We are very accustomed to the use of it. Again, thanks to COVID-19, all of us have taken or given such samples frequently. So that part of our physiology or anatomy houses a lot of bacteria, fungi, and sometimes even latent viruses. So it is teeming with microbes. It has its own microbiome. And amongst these, there are some which go and cause havoc, that is the true pathogens, and then they result in illness. So our challenge is to take a sample from there and then find out that culprit. So once we collect the sample, it reaches the lab. What we do is we take out that entire nucleic acid from it. So there are, if you see, if there are bacteria, and of course this area is full of bacteria, so there will be a lot of DNA, and most of these viruses are RNA viruses, so there will be a lot of RNA. So all of this, so while we have mentioned DNA extraction, I think we need to make it as nucleic acid extraction now that the viruses have RNA. And then there will be the host DNA as well. So the human cells are there. So when we are doing the extraction is non-partial. It will take out all nucleic acids. Then there is a part which is called the library preparation. So all this nucleic acid goes through these steps, which is called the library preparation in a sequencing test, where it is prepared for sequencing. The DNA or the RNA is prepared for sequencing. So all the RNA is converted into the complementary DNA. The DNA is already there. These are prepared and they are put onto a sequencer. When I say prepared, it involves a step. This is a targeted next generation sequencing. And this is slightly different from metagenomics. I will not touch on that part. If anybody has an interest, I can take it up during the Q&A. So once onto the sequencer, which is that pocket held device, every DNA will be sequenced. Everything that passes through those nanopores, the exact sequence of the ATGC will be mapped. And once we have this information, it will be taken to our software. Now it's the software's job to find out which are the host DNA, so it will eliminate those. Which are the commensal bacteria DNA, it will eliminate those. And then it will finally pinpoint on these particular set of organisms that we are interested in, and it will generate the report which we have seen. So sir, over to you now again for the case studies.
Thank you, Dr. Mahua. That was a that's an excellent sort of discussion. And you very beautifully told us about how the NGS sort of differs from the traditional PCR technique. Fantastic. Thank you so much for that. Because I don't think I've ever heard a better explanation than that. Very
Thank
good.
you, sir.
So let's now see a few cases which I had, when this first came to me, when Rohan first came to me and told me about this, I said, let me try it out on a few cases. And he was very kind enough to give it at a very low rate initially for just ensuring that I have some data on hand. So uh, this was a 11-month-old kid who came with fever, and if you look at I mean, the history is not here, of course, but the child did have fever and breathlessness and was not feeding properly for the last 3 or 4, 5 days, and we had to admit this child because even the X-ray did show a few patches. And we sent on day one itself, and by next day, including all the other tests that we got, we also got the flu-NGS report, and that showed mycoplasma pneumonia. So this was, as I told you, though it was mycoplasma, it was a fairly serious infection, and we had to put the child on azithromycin, etc. The child responded pretty well, and the it was quite useful to know that it was nothing, see, not one of the other strep pneumonia and other viral infections. So this is one of the things. The second case where we saw, uh, yeah, this also was a 14-month-old kid, a girl, who again came with a fever, fairly high grade, and there was also a history of fever in the family. There was another elder sibling also who had fever. So that child had responded, the child had fever had gone down, but this child was still having fever, and it was fairly high grade. So we sent, this child also had some coronary symptoms. So we sent the flu-NGS in this child also, and it turned out to be H3N2. At that time, if you look at the date out here, this was somewhere in Jan, 8th of Jan 2025. If you remember, most of us had seen many of these cases at that time. So this child responded luckily to oseltamivir, and the child did quite well. There was no problem. So because we came to know, we could immediately institute therapy. Yeah, this was an interesting child. This child, a 7-year-old kid, came fairly sick, and we had to put this child in the ICU because the child had some, what do you call? It was very tachypneic, and there was, of course, the child also had a history of hyperreactive heavy. So we had to admit the child, put him on oxygen, and we were just wondering whether my child might require ventilation. We sent the flu-NGS, and we started the child obviously on ceftriaxone because the child was quite bad, and IV fluids and therapy. Next day we got the report there was also influenza virus, so we added this oseltamivir, and the child's response was faster, definitely. So it does help. I mean, like here we had a mixed infection. We had probably the viral infection must have been first, and then the child must have had a superadded streptococcus pneumonia. It's an older child, 7-year-old kid. Okay, so that's how this kind of testing helps us. See, another important thing, as Dr. Mahua said, the COVID, probably these are all the good takeaways from COVID, that we have started doing so many more these OP-NP. I like that, by the way, oropharyngeal, nasopharyngeal. I really like that short form. So the parents are a little bit, what do you call, agreeable to doing that rather than doing a blood test. So when we tell them that we are not going to be collecting any blood and just taking a swab from the nose or mouth, then they are a little bit better. And definitely, as she has rightly mentioned, that if we can get a report which mentions the true pathogen, I think that makes a great difference. Method which she mentioned, that we were actually able to distinguish between commensals, the host DNA, and the pathogen. I think that's amazing. If we can do that, we are really progressing. Let me tell you a small secret. When I passed out my MD, even this, what do you call, the testing that we are doing right now, it's so much advanced. Even PCR we did not know at that time. All that is developed later on, and now even she's telling us that even PCR may be now outdated. Now we're going through this. I think the progress is something amazing. And if we can develop, I mean, we already developed this kind of a test, which in one shot it gives you so much information. It's just amazing. So thank you very much, Dr. Mahua, for this opportunity to share this with all the participants.